Hey folks, Scott Weingart here, and this is an EMCrit We. Today on the We, I have one of my former attendings, Marc Grossman, talking about his placement of an EZ-IO, an intraosseous burr hole for a young patient with an epidural hematoma, and the outcomes that ensued from that procedure. This has been on the list for a long time. It's a procedure I should have up on EMCrit, so I'm happy to have an opportunity to do that today. Very quickly before we get in, remember, we still have tickets on sale for our resuscitative ECMO course. That's Reanimate, November 2024, San Diego. Check that out at reanimateconference.com. And we have cohort 3 of our Flameproof course, which is our anti-burnout course. And you can find out more information on that at flameproofcourse.com. Flameproofcourse, one word.com. All right, let's get into the show with Marc Grossman on the placement of an EZ-IO burr hole. First question I'll ask you is the same one I ask everyone. Who are you and what do you do?
So I'm Marc Grossman. I've been an emergency physician. I graduated from my residency in 2000 and actually got the great opportunity to work with you when you were a resident of Mount Sinai. I'm an emergency doc now in New Hampshire. I work mostly at Portsmouth Regional Hospital, which is a larger city in southern New Hampshire, about an hour from Boston.
The reason I'm having you on the show is you recently published a case report on a topic that I've had in the database of a topic I need to do. And it was fortuitous that you contacted me with this case. So we'll let you relay the case and then people will quickly find out why we're talking to you. So tell us what happened.
Great. I was snowy night in February, and I was at a smaller community hospital in southern New Hampshire, a level 3 trauma center. It essentially means that you have a surgeon that's available, but not really a lot of other subspecialties that are required. And in New Hampshire, what's amazing is I've never had so many people walk in with critical illness and critical injury. The example I always give is I had a stroke patient who wound up getting TPA or TNK, and his symptom onset was like 45 minutes before he got there. He drove himself to the hospital, and he was completely paralyzed on the right. And I said, but I don't get it. Why did you drive to the hospital? He said, because I didn't want to pay my copay. I said, okay. So let me ask you, how did you drive to the hospital? You're completely paralyzed on the right. He said, I just kept making left-handed turns.
That's fantastic.
Right? So I said, of course you have an answer. This patient that I had was similar, where she was involved in a rollover car crash. It was on the highway. It was about 2:00 in the morning, and EMS got there. She was awake and talking and said, no, I'm good. She had a big goose egg on her forehead. And they said, we really should go to the hospital, right? But they didn't force her to go. And essentially, they let her go. And the boyfriend's father came and said, yeah, let's go to the hospital. So they drove her to my hospital. And at a level 3 trauma center, it's me and 2 or 3 nurses. I'm the only doctor in house. And she walks in and very dramatically, and we have the video of this, but she walks in and she's being assisted in and then collapses at the threshold of the front door.
Yep, the just make it to the ED phenomenon.
Just made it, like crossed the threshold. And she's vomiting. And I'm in the room with another patient, and they're like, oh, we have a trauma alert, which doesn't really mean much. But there's not anybody else that's coming to help. So put her in the stretcher, and I'm examining her, and it looks like just isolated head, but I put in the orders. We get a CAT scan. CT tech comes, and she's, can you come look at this? And I look, and she has a huge frontal epidural hematoma, and she's herniating. On her exam, she wasn't doing much, but she was bradycardic and hypertensive already. She had a blown pupil, and I intubated her. And I said to the secretary that was there, can you please call for the helicopter? Because I just got to get her out of here. I don't care where she goes, just have to get her like someplace for definitive treatment. And he calls the helicopter, and they're not flying because it's snowing. So I had to manage the patient myself, and I knew what needed to be done. She was herniating. Like I said, I have her intubated. I have her the head of the bed up, and I call Boston Hospital, and they have a back line for their ER. So I talk to the emergency doctor, who's amazing. And she's like, hang on, let me get you on the phone let me get the neurosurgeon, 3-way call. And she gets through the neurosurgeon very quickly. And I explain the situation. And he said, just give hypertonic saline and mannitol, just manage her medically and get her evacuated like as soon as you can. And I said, she's not going to make it. Like, that's just a temporizing measure. It's not going to work. Like I said, I know what I need to do. I just haven't done it. I think I did it in residency where, you can smell the neurosurgeon attending's cologne. Like, he's leaning over you and basically guiding your hands, and you're using the hand crank trepanation needle, and you do it, but you're not doing it by yourself, and you're not doing it in a life or death situation. It's a very controlled environment in the operating room. I think I'd done it once, and again, it's been years. So I said, I need to drain her, but can I show you at least the CAT scan? So he gives me a cell phone, and I FaceTime with him, and I'm showing them a CAT scan, and he says, the quote I remember, there are certain quotes I remember very distinctly, but he's like, "Oh shit." Okay. So I agree. And so I'm running through the CAT scan, and then he starts doing these calculations in his head, and he uses the word pi. So he's figuring out the volume of the blood and how much blood I'm going to be able to drain. He's okay. Now bring me over to the patient. So I bring my phone over. She's sitting up. She's intubated. And I show him what she looks like. And he's like, all right, bring me back to the CAT scan. So I bring him back to the CAT scan, go through the 3D images. And he's okay, bring me back to the patient. So I go back. He's got a Sharpie. So he says, okay, so no, a little bit lower, right there. So that's where you're going to drill. He said, what are you going to use? And we may or may not have had the neurosurgeon's trepanation drill, but I don't know how to use it. And I said, I'm going to use the EZ-IO. And he's great. What's that? So I showed it to him. He'd never seen one before. He'd seen an IO. He had some pediatric experience. So I show it to him, and he's okay. And what are the needles? And I said, it's 15, 30, 45, whatever. And he's like, you need something that has a larger bore, something that's wider. I said, it's length. It's not width. He's okay. I guess the blue one looks good. All right. So I get everything ready, and I'm like, okay, I have to put the phone down, and I get the drill ready, and I'm making it like as sterile as I possibly can. And the nurse is over my shoulder staring, and she's like, I can't believe you're doing this. I'm like, okay, don't say anything unless it's actually helpful. And I just take the drill and drill. And then I had a loss of resistance. I'm like, okay, I guess I'm in. And I was it was in the frontal. So I was like, first scared that I'm going to go get it into the orbit somehow. And then obviously scared that I'm going to drill through and touch brain, which there was enough blood where that wasn't going to happen. So I disconnected, put a syringe, and pull back, and nothing comes back. And I'm like, okay, what does that mean? Is it just already coagulated and congealed or whatever? So I take a little bit of saline, a cc of saline, just flush it, figuring it's just in the needle. And that worked. And I start pulling back, and I got 50 cc's of blood right away. She starts to wake up.
Wow.
And her pupil goes down. And I said, great, let's get another CAT scan. And I think you actually have the image that was in the paper.
Yep.
So the CAT scan with the IO needle inside in the right place, but with the blood actually reaccumulating. So I had to pull off some more blood, and the transport team was there. I put the mother in the front seat, and I said, she's in great hands. She's going to be okay. She's already getting better. And I explained to the nurse, just the hospital, the local trauma center was only like 20 minutes away. And I said, if you need to just pull back. So I connected with a 3-way stopcock, and I said, just pull back if you need to, but try not to touch it. But if she starts deteriorating, or the heart rate drops, or the blood pressure starts spiking, then just take off some more blood.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this, and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap, and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
And she made it to the hospital, and the nurse came back, and I said, "How is she?" And she said, "I don't know, she's in the OR." And I continued my shift. I was like a zombie at that point. I was like so emotional. And then I drove home, and I have to be honest, I went into my home office and I just sat down on the floor and I started crying. Like, it was just such an emotionally draining thing. And I had no idea what was going on. And I get a text message from an unknown number saying that she's okay. And it was the PA from the neurosurgeon from the trauma center. I guess somehow he got my number. And he sent me pictures of her post-op and her CAT scan, literally extubated, sitting up and giving the thumbs up. And that was like 10 o'clock in the morning. It was one of, and I've been through some crazy situations. I'm on one of the search and rescue teams and field amputations. And this was probably the most emotionally charged and draining situation I've faced in my career.
Yeah, I can imagine. Amazing save, amazing job, but emotionally laden beyond any reckoning. So let's talk a little bit more about the procedure itself. Now, you obviously did a bunch of research and reading for the case report you wrote, so you're familiar with the work of others on this. There's some back and forth about whether a skin incision should be made so that the IO drill is just going through the skull itself and not having to go through soft tissue. What's your take on that?
So I didn't. I was thinking about it, but this one was in the forehead. So I think there was enough, the skin was thin enough that I was going to be okay. But I get it with the trepanation needle because it's the drill, because it's not necessarily sharp. It has to just grind the bone down. So I know you have to do it for the standard drill. And I think for the EZ-IO, because it has the trocar, I'm not sure you need to do that, right? Because the trocar pierces the skin and you're not releasing the trocar until you're all the way through the bone.
Yeah, no, that makes complete sense. I think the argument I would make, and I don't have a stance on this because I don't argue about things I've never done. So this is all theoretical. So I'm just raising points other people make, is consistency of needle length. If you take all the soft tissue out, then you know you could use that short blue needle without having to worry.
Right.
And you reached in this case clearly because you had a CT that you were able to measure, you knew. But if you don't, then you don't need to worry about needing a longer needle for a patient with more abundant soft tissue. I think you were lucky in that, first of all, you had CT imaging and you had a neurosurgeon willing to do all these calculations to pick this optimal spot, which brings me to my next question. Would you have done this if you couldn't have gotten in touch with a neurosurgeon? Now, I don't know if in the US that even is a possibility, but I know for our international listeners, that might be the case. And you said you knew what needed to be done. Let's say you just couldn't get a neurosurgeon on the line. Would you have done it anyway? And how would you have done it differently?
I would have done it, and I would have done it the same way, except minus the input of the neurosurgeon. His input, I think, of course, now that I've done it and I have more confidence, I wouldn't hesitate to do it if it was appropriate. You can't be too cavalier, obviously, but I think I'd be more willing to do it in the future, having had this experience. But if I couldn't reach the neurosurgeon, I still would have done it. And again, in the future, I would definitely do it if it was appropriate.
Nice. Now, with a significant size epidural, the risk is seemingly pretty low as long as you pick a reasonable spot where you're not going to hit into the temporal artery or into the orbit, as you mentioned. Either you're going to reach it, which is great, or you're not, but you're not going to really hit brain, just as you alluded to when you were discussing it, because the needle size compared to the hematoma size, you have a huge buffer of safety. Has that been your experience in the reading you've done as well?
Yes. Unfortunately, with the EZ-IO, the readings, the cases previous to mine weren't really successful in terms of surviving.
Yep. Why do you attribute? What do you make of that?
I think it was just self-selection. Like, why did they have epidurals? They were older patients with other comorbidities, so they didn't do as well. I got mine relatively early, and she was young and healthy. And I think the location of it made it easier for me to access. I didn't have to worry about the temporal artery or anything like that anatomically. So it was just easier for me to get in the right position and make an effective drainage.
Absolutely. Now, the Easy IO has obvious advantages from our familiarity with it, and it just feels safe. But it does make a smaller diameter entrance into the skull, which with clots may be an issue. If you had both of them in front of you and a neurosurgeon on the phone, would you say the Easy IO is still the way to go because of the familiarity, or would you say that maybe there's an advantage still to the classic manual trephination drills?
I have to say that number one, the Easy IO is basically everywhere, and people really are familiar with it and they're very comfortable with it. And I asked Teleflex about it, and I said, is there a way to, and they said it's like, it would be such a hurdle, such a process to get this through. My understanding is that there is a larger bore Easy IO or an IO needle that they use for bone marrow aspirates, like from the hip. I'm not sure if it's Teleflex or I actually couldn't find it, but people keep talking about this, that the hematologists are using. That'd be great if you had something like double the size and the same length and the same device, but I haven't been able to find it. I would still use the Easy IO because you know what? If the Easy IO doesn't work, then I'll go to the standard drill.
That makes sense.
I don't have a comfort level with the standard drill, and I don't think I ever would as an emergency physician. I can't imagine an emergency physician that would have that, even if they practice with it. And when you look at the process, it is a longer process, more involved. I just wouldn't be comfortable doing that. So if I needed to, I had it in front of me and I had a neurosurgeon that was telling me what to do, I think I would start with the Easy IO, drain what I could. And if it just wasn't working because it's already clotted, then I would go to the trepanation.
I think you're on the right track. Having done a bunch of bolts and caminos with the drill, I do have experience with that. It is a more involved process. And even after you get in, you still have to get the dura. And I think you're absolutely right. I think that's the way to go. All right. Is there anything we should have discussed that you would want to get out there about this case or about the procedure in general?
I think that emergency physicians should familiarize themselves with the options they have available to them. If you have Easy IO, just at least talk it out, think about it. How would you do it if this patient came to you? How would you do it if it was in the temporal lobe or another part of the brain as opposed to frontal lobe? And just think about it and walk through the steps that if this came up today, I would be able to do it. And this is how I would do it.
I can't thank you enough for coming on. Really appreciate it. And amazing work on this case. And
thank you so much.
You put it into the literature.
Thank you.
All right. So there's the episode. If you've ever done this and you have tips or tricks you want to add, please put them in the comments for this episode. I think the take-home messages are, don't do this without a CT scan unless you're in an under-resourced place where you just can't get a CT scan. Base your needle location and which Easy IO size you would choose and whether or not you need a skin incision, because even the bigger one won't reach, though I think every case, the larger Easy IO needle would. Base that needle choice and location on the CT imaging. And if you're in anywhere that has ready accessibility, which I mean means all of the places most of the listeners are in, talk to neurosurge and get them on the phone, and that will give you the feeling that it's not just you making this decision. But I think if you can't get neurosurgery and a patient's like acutely herniating, then the placement of this small needle into the middle of a pocket of an epidural or subdural is probably still worthwhile, because I think there's tons of upsides and very, very little downside. The only contraindication listed consistently in all the resources I've checked is coagulopathy, but I don't know. I mean, if the patient's actually herniating in front of you, I think even coagulopathy would not prevent you from placing an Easy IO, is my take on it. If you have a different feeling about that, please respond. But I don't think that would stop me. I think I'd be actively reversing whatever coagulopathy they had while I'm placing that Easy IO into the patient. I think it might be a different situation. You know, it's much akin to the difference between placing a formal chest tube and doing something like a pigtail, where, you know, it's a much different amount of potential bleeding. But you let me know what you think. This has been Scott Weingart for the EMCrit podcast saying bye-bye.